me plaisir de vous présenter notre invité spécial d'aujourd'hui, Dr. Pim Cuijpers, qui nous vient de Hollande, qui est professeur émérite Universiteit Amsterdam, qui est directeur du centre collaborateur de l'OMS pour la recherche et la diffusion des interventions psychologiques. Dr. Cuijpers est spécialisé dans la conduite d'essais contrôlés randomisés, des méta-analyses sur la prévention et les traitements psychologiques des troubles mentaux courants. Une grande partie de son travail est axée sur la prévention des troubles mentaux, les traitements psychologiques de la dépression et des troubles anxieux, et les traitements dispensés par Internet. Il a également publié des articles sur un large éventail de sujets dans le domaine de la psychologie clinique, notamment le traitement psychoéducatif, les interventions précoces, les troubles psychotiques, les aidants des patients atteints de démence et la bibliothérapie. Il a publié plus de 1200 articles, chapitres, rapports et publications professionnelles évalués par des pairs, dont plus de 950 articles dans des revues scientifiques internationales évaluées par des pairs. Il est un des chercheurs les plus cités depuis la première édition de la liste de Thomson Reuters Web of Science en 2014. Il est classé numéro 1 dans le domaine de la psychiatrie et psychologie en tant qu'auteur de premier plan, selon le Web of Science. Selon Expertscape, une organisation qui classe les chercheurs en fonction de leur expertise dans les domaines biomédicaux, Dr. Cuijpers est le premier expert mondial en matière de recherche sur la psychothérapie, le premier expert en matière de dépression et le deuxième en matière de meta-analyses. Il est de plus rédacteur en chef du Journal Consulting Clinical Psychology et également rédacteur en chef adjoint de la Clinical Psychological Science. En 2024, il a été le premier Européen à recevoir le prix de l'American Psychological Association pour ses contributions professionnelles exceptionnelles à la recherche appliquée.
Thank you very much. Also for the invitation. I couldn't understand everything, but I hope it was good. And I'm very happy to be here. I always like to talk about my work on psychological treatments. So that's an honor and a pleasure to be here today. And what I want to do today is I want to give an overview of what we know about psychological treatments. And we can do that because we have a complete and live overview of all the randomized trials in the field. And I want to talk about, it's also it's also a new approach to meta-analysis, because we have all these meta-analyses and everybody's doing these searches, and the number of meta-analysis is increasing and increasing, and everybody does that work, and then you have small meta-analysis on this and that. We try to do it differently. We try to give an overview of the whole field, and then look at all the sub-questions you can ask about that. We do not only do that for depression, but for all mental disorders. But today I'm going to talk about what we know about psychological treatment of depression, because that's by far the best psychological treatment available. There are more than 1,000 trials now. I think we're now at 1,150, and that's increasing every year. And so I want to summarize that. And what I will show is that the effects are good, but not that good. And we really need better treatments. And I will briefly talk about how we can try to improve treatments and what research is now being done to improve these treatments. So that's what I'm going to do. And I will also try to, if I have time, I don't know exactly how much time I have.
2 o'clock.
Until 2 o'clock, yeah. Then I certainly also have the time to show you the website where you can do your own meta-analysis. So we have made all these data open, and if you want to know whether group therapy works in East Asia or CBT works in older adults, you can go to our website and run your own meta-analysis there in a few minutes, and I will show you how to do that. But let's first talk about the content. Yeah, so the problem is that, as I said, meta-analyses are there's an overproduction of meta-analysis. Everybody does all these new meta-analyses, and we see that increase in randomized trials, but we see an even larger increase in meta-analysis and systematic reviews. And it's a waste of time and resources because everybody does that all over again. And what they're not always good. I mean, most of the reviews that I get for my own journal and which I review the quality is not that high. Of course, many of them are very good, but you get this enormous field of meta-analysis, but it doesn't really add much anymore. So what we try to do is what we call meta-analytic research domains. You don't do one meta-analysis. In the meta-analysis, you look at psychological CBT versus other psychological treatments, or psychological treatment versus antidepressants, or versus combined treatments. And then you get one meta-analysis. What we do is we look at all the randomized trials on psychological treatment for depression and for other disorders, but today we're talking about depression. So we take all the randomized trials, regardless of the comparator, meaning that we have digital therapy versus group therapy, inpatients treatments. We have face-to-face versus digital, group versus individual, CBT versus IPT, psychodynamic versus counseling, everything. We have everything. And we update these searches every 4 months. So everything we have is up to date. And we can, so it basically means that we try to get everything you can know from randomized trials, we get that into our databases. So this is the website. I will show it later to you, but let's do that at the end, then you get an idea, then you get a better idea of what you can do with it. So the next part, what does it tell us about psychotherapies for depression? So, as I said, 1,150 randomized trials. And the number of trials is still increasing every year. It's really, I think it's not needed. I mean, with this number of trials, what does a new trial add? But anyway, that's not what happens. It goes on and on and on and on. And that means that we know about psychological treatment in primary care and specialized mental health care, in older adults and perinatal depression, all these different target groups, we know everything about it. And so let's try, if you want to read an overview. So I started with this in 2007. And at that point, I thought, okay, I'm going to collect all this data and I'm going to write 1 or 2 or 3 papers about it, and that's it. But it never stopped. And so since then, we have published more than 100 meta-analyses, updates, and new themes that came up. If you want to, sometime and every 5 years, we make an overview of what this research shows. And most of it I will talk about today, but if you want to read about it, you should have this paper in the Journal of Affective Disorders 2 years ago. Earlier this year, we published a paper. That's what I want to start with. It's about 5 decades old. So the first randomized trials were on psychological treatments for depression, were done in the 1970s. And so what we did is we looked at this whole field, not only in terms of outcomes, but also on how did the research develop. So what kind of research how did that change over time? And we also looked at the outcomes, of course, but it's still very interesting. So these are the target groups you can see in this graph. And what it says basically is that the number of trials in adults in general and the number of trials in people with comorbid general medical disorders is significantly larger than in other target groups. For example, in children and adolescents, the number of trials is decreasing when you compare that to research in adults, which is important because in children and adolescents, we also find smaller effect sizes, while the research is decreasing. So from a clinical perspective, you would hope that the research would increase because we need better treatments, but the opposite is happening. And I think that's very important. And in terms of therapy, I will show that later also, CBT is by far the best examined type of therapy. It's not better than other therapy. It's not more effective, but it's definitely about half of the trials on psychological treatments are on CBT, while all the other ones, which usually have a few dozen randomized trials showing that it's effective, like interpersonal psychotherapy, psychodynamic therapies, counseling, behavioral activation, problem solving. In older adults, there's quite a lot of research on life review therapy. They're all effective. There's no evidence that one is better than the other. But the research on CBT is still getting more and more dominant. Yeah, and when you look at where that research is being done, traditionally it's done in the US. For these studies, we've looked at studies in North America, which includes Canada. But of course, most of these trials are done in the United States. That started in the 70s and until almost the mid-1990s, that was almost exclusively done in the US. But since 1990, you see there's more and more research in Europe. And now there's more research in Europe than in the US. And since the 2000s, you see that there is also more and more research being done in other countries, especially in East Asia. And that's increasing extremely fast in the last couple of years. So at some point, East Asia will be as big as Europe and the US. That will not take that long anymore. But if you look at the outcomes, so we did a large network meta-analysis in which we took all the psychotherapies with at least 10 randomized trials. And we took all the studies that compared these types of psychotherapy with each other or with care as usual or waitlist control groups, and also placebo, but there are only a few of those. So we had, I think, 300 something trials. This is the network. As you can see, there's almost, CBT is so very dominant. But it's still also the other therapies are pretty well examined, and the network is reasonably well connected. But the outcome, so 330 trials, 34,000 people, CBT, IPT, psychodynamic, all the major types of psychotherapy are there. The effect sizes varied a little, but they were not significantly different from each other, meaning that all these therapies have comparable effects. We did find that counseling was a little less effective than other therapies, but we looked into that in more depth in a specific paper, and we saw that counseling is often used as a control condition. So then it's not a real therapy, but it's intended to be a control condition, controlling for what is usually happening in a therapy. And in the comparisons where counseling was a serious treatment, so where people were trained and where it was an active treatment, you didn't see any difference with other therapies. It was only in those where it was explicitly used as a control condition, that it was less effective. So probably we don't know, but probably it's also effective as with comparable effect sizes, although that's uncertain until now. We also looked at the long-term effects. So we found longer-term effects. We're looking into that now in more depth, and we have about 200 trials in which psychotherapies are compared with control conditions at least 6 months follow-up, and our trials with 5 years follow-up. And what I cannot say we haven't yet started with the final analysis, but it looks like that psychotherapy has a long-lasting effect even after a couple of years. So you see that the effects are large and then decrease, but they remain stable at a moderate effect size over time, which lasts a couple of years, suggesting that it really has a long-term effect. But again, this is not published, and we're not even in the final analysis yet. So we did this. We also examined this separately for CBT. So we did this separate large meta-analysis of CBT for depression with 400 trials and 50,000 people, basically showing the same thing. It works, but it does not work better than other therapies. And the combination is better. I will come back to that, how it compares with pharmacotherapy. The problem with most meta-analyses is that they're reported in terms of effect sizes, Cohen's d, HSG, the standard mean difference. And that indicates the difference between the treatment and the control group after treatment in terms of standard deviations, which is the best indicator of the effect, definitely, because depression is a continuous variable. It's not something you have or don't have. So you have to work with continuous outcomes. And then looking at the normal distributions with the mean and standard deviation. So standardized mean difference is a good outcome. But unfortunately, it's very difficult to understand what it means. How are you going to explain to a patient that if you get this treatment, that the chance of getting better is 0.5 standard deviation? Nobody will understand what you're talking about. So what we did is we looked at the absolute outcomes. And so that's methodologically complicated because it is automatically very heterogeneous. And many people would say, can you do a meta-analysis of absolute outcomes? But we thought it's clinically so important to know that we still did it. And you have to be careful with the interpretation, et cetera, et cetera. But it gives a rough indication of what happens. What's the chance of getting better when you get therapy? We used a statistical trick. So a lot of papers report response. Response defined as a 50% symptom reduction from baseline to post-test. But most studies don't report that. So we estimated that based on the means and standard deviation. So the means and standard deviation give you a normal distribution, and then you can estimate where on which part of the standard deviation 50% response is. And we used, it's a statistical trick. We have validated that in a few studies, and it correlates with 95% with the actual response rates reported in papers. So we had 228 randomized trials. We looked at response, remission, defined as a Hamilton D score below 7, reliable improvements and reliable deterioration. And we did that separately in the treatment and the control groups. So this is what we found. The mean response rate in psychotherapy is only 41%, which is not really, that means that the majority of people who get we're talking about brief protocolized therapies, only 41% of people respond, which is good. It's a lot better than the control groups. As you can see, that's 17, 16%, but it's still pretty modest. And we looked at it in all kinds of different ways. It was pretty robust, that 42%. Remission rates, so that people are completely recovered and not discernible from the general population, that's only 26%. So pretty low indeed. And there is this small group of people who deteriorate during therapy, people getting worse. That proportion is smaller than in the control conditions, but it still happens in about 1 in 20 patients that they get worse during therapy. We have to be careful with this, with these response rates. So the 41 or 42%, that's the average. But we've done a separate study in which we looked at baseline severity. And it looks like that this is not published, it's submitted, so you cannot cite me really on this. But it looks like that the response rates are higher when baseline severity is higher. So in more depressed people, the response rates are better. And this is done with these common metrics. So that makes it possible to convert depression scores to the general population, where 0.5 is the general population, 0.6 is one standard deviation above the general population, 2 is 2 standard deviation, etc. So you see when people score more than 3 standard deviation about the average population score, then you see that the response rate is above 60%, which means basically that if you're working in specialized settings where you are probably working, there you probably have higher response rates. Yeah, well, we also looked at these in a separate paper. We looked at these response rates in usual care in usual care. And we looked at usual care control groups in specialized mental health care and primary care and somatic care and perinatal care. And so because they are these usual care control groups are used in randomized trials. So we can see what happens in usual care over time. And so we looked at what happens, what are the absolute response rates in usual care, in primary care, in specialized mental health care, and it's a flat line over time. So usual care does not improve. And we keep on using usual care as the most important control group, but you would hope, and then we find that these psychotherapies are showing that are better than usual care. That's what we consistently find. But apparently these psychological treatments are not translated back into usual care because the usual care response rates are a flat line over time. Usual care is not getting better. That can mean different things, by the way. Yeah. So we looked at these absolute response rates in a series, because we have all these different data sets of psychological treatments across all these different mental disorders. And here we looked at 50% symptom reduction in 8 mental disorders. And depression was actually one of the highest response rates for anxiety disorders, for OCD, for PTSD. these response rates are between 30 and 40%. And for borderline, it was only 25%. So this problem of these modest response rates is not only for depression. That's something that happens in treatments across mental disorders. Yeah, so another thing that we looked at is how can we apply psychological treatments? Does that have to be individually, or can that be done in groups, by telephone? Can that be done digitally through digital interventions? And so in this network meta-analysis, we only looked at CBT in order to reduce the heterogeneity. So we included all trials comparing individual CBT with group therapy, individual with guided self-help, with unguided self-help, and guided self-help is usually done digitally. So almost all trials on guided self-help use internet-based digital guided self-help. And for unguided self-help, that's all digital. So then you go to the internet and apply CBT to yourself with all the instructions there. And so that's what we examined. Do they differ? And this is what we found. We found no significant difference between group, telephone, individual, guided self-help. So as long as there's human support, the effects are comparable. No indication that digital interventions are less effective, at least when there's human support with it. When there's no human support, so unguided interventions, they're clearly less effective. And I will say a little more about that. It's a little more complicated. But overall, you can say that any format in which you deliver CBT is effective, as long as there's human support. We also looked at differences between age groups. So we had all these studies in children, adolescents, young adults, middle-aged adults, older adults, and even a group of studies in older adults. We had about 10 trials in people with a mean age above 75. So these are older adults. And well, this is what we found. Again, there's no difference between age groups in adults. So young adults, older adults, old, it doesn't matter. The effects are not significantly different from each other. However, in children and adolescents, the effects are significantly smaller than in adults, especially in children. And in adolescents, they are smaller than in adults, but a little larger than in children. In another study, I don't have time to dive into that too deeply, but there we saw that smaller effects in adolescents are not so much because the response rates in the treatment groups are lower. It's because the response rates in the control groups are higher. So we found there also about a 40% response rate in the treatment groups, but in the control groups, you saw that the response rates were much higher, about 25%. So treatments work in the same way, only in the control groups, which makes sense because in adolescence, it's often more a transient state, which can be changed by different factors. So most trials examine only depression as an outcome, but we have so many other outcomes which are examined in a lot of other studies that we can also say we know a lot about other outcomes. So we've looked at quality of life, social functioning, levels of anxiety, self-esteem, hopelessness, dysfunctional thinking, social support, suicidality. And so what we usually find is that psychological treatment of depression has also effects on the secondary outcomes. Only the effect sizes are more modest than on depression, which is good. I mean, that means that that psychological treatments on depression do not just reduce the depressive symptoms, but also a lot of other problems that people with depression have. So that's good news. There's also a small group of studies in mothers with children, and we have just updated it. It's not published yet, but it's in line with what this early study shows. And that shows that if you treat mothers with depression, then you also find significant effects on the mental health of their children and on the parental functioning and on the interaction between mothers and children. So that's really very good news. Unfortunately, there's very little research on people who have comorbid disorders at baseline. So people who have depression and anxiety, or depression and a personality disorder. I think we have only 2 trials in people who have depression and a personality disorder. So we don't know if it's effective. But we do know that in the 3 largest groups, so there are quite a few trials in people who have depression and anxiety, people with depression and insomnia, and depression and substance use problems. And what we see is that in depression and anxiety, you see that both the depression goes down and you see that the comorbid condition goes down, so anxiety and insomnia. That's not the case in substance use problems. So if people have depression and substance use problems, you see that the effects are small, both in depression and in substance use. So that's really a very complicated group. And there's not enough research in other comorbidities. If you talk with people who work in specialized mental health care, they often say, yeah, but most of my patients do not just have depression, they also have a personality problem. That's probably true, but we know nothing about what the impact of that is on the outcomes of the treatment. There's also quite a group of studies in subthreshold depression. So in people who do not meet diagnostic criteria for a major depressive disorder, but do have some symptoms. And so psychological treatments are then aimed at reducing these symptoms, but often also at preventing the onset of major depression. And what we see is that up to 1 year, you see that there are effects in reducing the subthreshold depressive symptoms. And you see also an effect on the incidence of major depression, because they don't have a major depression at baseline, they're excluded. And then you can look at the incidence of new cases of major depression at follow-up. And we see that that works until about 1 year. And after that, the number of trials is very small. So, but there is no evidence that it works after that 1 year. But up to 1 year, you can effectively reduce the incidence of new cases of depression. Well, we have examined all kinds of other things. I want to show a few things. The interesting thing is that we do not find an association between the number of sessions and the outcome. So a therapy with 3 sessions is just as effective as a therapy of 24 sessions. We do not find an indication that there is an association between the number of sessions and the outcome. Also not between the outcome and the contact time. So what's the total? Some sessions are 30 minutes, other an hour, and sometimes 1.5 hours. And when you have 6 sessions of 1.5 hours, that's of course much more than 12 sessions of 20 minutes. And there's no association between contact time and outcome. Also not the length of treatment. What we do find is that the frequency is associated with the outcome. So if you have 2 sessions per week, then the therapy is more effective than 1 session per week. We tested this in a new randomized trial, which was published a couple of years ago, and we could confirm that. So there is a very good chance that if you have 2 sessions per week, that the effects are larger than 1 session per week. There's quite a lot of research in low and middle income countries. What we find in these studies is that these effects are actually larger than in Western countries, but that could be an artifact because the risk of bias is unclear. Care as usual is, of course, very different in low and middle income countries. It usually means that you get nothing, while in high income countries, care as usual can be quite substantial. These kind of things. So what we say now is that psychological treatments are at least as effective in low and middle income countries than they are in high income countries. We've looked at all these different specific target groups like student populations, people with comorbid general medical disorders, heart disease, cancer, diabetes, etc., perinatal depression. And we do not find any indication that psychological treatments are less effective in these target groups. No indication whatsoever. We do find that the effects are smaller in primary care than in specialized care. But again, that's not because the response rates in the treatments are lower, but because the response rates in the control groups are higher, just like in adolescents, which also makes sense in primary care. So, but the effect sizes, so the relative difference between treatment and control is lower in primary care. We also find smaller effects in inpatients, but that also shouldn't come as a surprise because the control conditions are very different from what you see in outpatient settings. Yeah, so what we also try to do, so we have about 1,150 trials in our database, but we have specific projects in which we try to get the primary data from the randomized trials. So in total, we have about primary data of about 200 randomized trials now. But that's, of course, a very different project because it's much more time intensive to get these data, to harmonize them, and to do all these analysis with it. But we have a pretty complete overview or data set of randomized trials in digital interventions for depression. And this is a very nice study. And why do we want these IPD data sets? There are 2 main reasons. The first is that you cannot really examine predictors of and moderators of outcome in single randomized trials because they're powered to find an effect of the intervention. They're not powered to find predictors or moderators. And so they're always underpowered to find predictors and moderators. When you put all these data sets together, then you do have enough power and you can do good research into predictors and moderators. The other reason why we do this is because you can also look at the rare outcomes. So we use this trick to estimate the number of people who deteriorate. But in IPD meta-analysis, you actually have the data, so you can see how many people deteriorate. But this is interesting. I will show you. This is a individual patient data network meta-analysis. So we included trials comparing guided self-help, digital guided self-help, with unguided self-help, and trials comparing guided self-help with control conditions. So we had 3 nodes control, guided self-help, unguided self-help. And so I'm not gonna go into all the details because I don't have time for that. But this allows you to predict who will benefit from which, who needs the guided intervention, and for whom is the unguided intervention good enough. So if you go to this webpage, you can fill in all the characteristics at the left side. So baseline severity, age, gender, and a few other things. And for that specific patient for which you fill in the details, you can see whether this person benefits most from guided or from unguided interventions, or that they won't have a benefit at all from anything. Overall, we found that in mild depression, the difference between guided and unguided doesn't exist. They're both effective, both better than control conditions. But when severity goes up, then guided interventions are better. But I think this is a very nice step up to personalized treatments, because you can predict here who will benefit from which treatment. But this was the good news. Now the bad news. So that we have all this research on psychological treatments, but the effects are heavily overestimated because of different reasons. The use of waitlist control groups, there is now very convincing evidence that if you use waitlist control groups, that you overestimate the effects considerably, with a standardized mean difference of about 0.3, which is almost the same as the difference between antidepressants and placebo. So it's quite substantial. Most have some risk of bias, about 80% of the randomized trials. We have the problem of publication bias. We know that it exists. We've looked into it. We've looked into the NIH-funded trials and see whether which ones were published and which ones were not. And we got the data from the ones that were not published. And what we saw is that 25% was not published. And when you include the data from the unpublished studies, you see that the effect size goes down with 25%. So if you look at all these things together, we've done that in a few studies. If you look at all these methodological problems together, the effect sizes drop with about 50, they drop into half. So that's substantial. It's not different from antidepressants, by the way. That's it's the same everywhere. So let's go to antidepressants. We did a large network meta-analysis of psychotherapy versus pharmacotherapy versus combined treatments. So we included all the comparisons between these three. And what we found, 100 trials, and what we found is that at the short term, psychotherapy and pharmacotherapy have comparable effects, and combined treatment is better than either psychotherapy or pharmacotherapy. At the longer term, combined therapy is still by far the most effective, but also psychotherapy was a little better than pharmacotherapy, and the dropout was lower. We did another meta-analysis in which that was led by my friend and colleague Toshi Furukawa. We had a somewhat different approach there. We looked at the maintenance treatments also. So you have an acute phase, acute treatment, and a maintenance treatment. And we included trials with any treatment in the maintenance phase. So people could have pharmacotherapy, psychotherapy, pill placebo, combined treatment, whatever. And in the maintenance phase, they could switch to any other treatment. So you have a lot of switch and possibilities, but we looked at all the possible combinations and did a network meta-analysis of that. And so we had 80 trials, almost 14,000 people, whatever. This is the network plot. What we found is, again, combined treatment is by far the best treatment. But we also found that psychotherapy is better than pharmacotherapy at a longer term outcome. Even once psychotherapy is better than taking antidepressants for the whole year. I think this is an important study, and this was used by the WHO and their new treatment guidelines to recommend that actually pharmacotherapy should not be prescribed without psychotherapy. Of course, in low and middle income countries, that's not possible often because there are no psychotherapists. But if possible, you should not prescribe antidepressants alone. Okay, how am I doing in time? So this is a summary of what we know about psychological treatments of depression. And there's much more, of course, but I don't have the time to go into all the details. So we need better treatment. So I already said that care as usual has not improved. But what we also see is that the effect sizes have not improved. So this is from a paper in the American Psychologist last year. And so yeah, we looked at the effect sizes and it's a flat line. And we have seen a lot of new therapies. We have seen, ACT, and we have seen mindfulness and compassion-based therapy, and schema therapy is now fair. And we've seen all these new therapies coming up, but it has not resulted in an increase of the effect sizes. The effect sizes, no new therapy has been proven to be more effective than the ones who already were there. And I understand you have a very long tradition of psychodynamic therapies. And my guess would be that the psychodynamic therapies that were done before CBT came up in the 1970s were just as effective as CBT. Only there were no trials. But then CBT came, and you can examine it, of course, very well, and you can. But since CBT came, there are all these new therapies which claim that are even better than the ones that were there. But no, that's not how it works. It's all these therapies have comparable effects, and we waste our time if we invest too much in all these new therapies, and they usually are based on the problem that I showed, that many therapies don't work. As a clinician, you always see people who don't respond to treatment, and you think, did I do the treatment well? Do they have a depression? Maybe we didn't do the diagnostics well. But there is always this problem that there are a lot of people who don't respond, and you're always looking for this new way to do it better and to make it better, and then somebody comes, we have a new therapy based on clinical experience. And they have a very convincing story, and they come up, yeah, you have to be trained, and courses, accreditation, but in the end, no patient gets better. That's what we very clearly see. So what we have to do that differently. We have to, in one way or another, have to change the innovation cycle of what we do. And so for a paper which is not published yet, but it's accepted in World Psychiatry, we looked at all the innovations that are currently being examined. And we found lots of them. We found more than 30 of them. And we looked at the state of the evidence where they are. Some are very, very promising and very, so we categorized them in 4 domains. The digital domain, where you have the the normal digital interventions, but also the apps, the ecological momentary interventions that you can use through your smart watch, the just-in-time adaptive interventions, which try to see when something happens right now so that you can intervene right now. You have serious games, VR, augmented reality. There are more and more attempts to integrate digital interventions in routine face-to-face care. You have, of course, now AI, the chatbots with AI, which promise to innovate the whole field again. You have avatar therapy. And then you have the whole field of personalized treatments. I talked about the IPD network meta-analysis, where you can find that. But you have to think, if you want to show that that really improves routine care, you have to do a new randomized trial in which you randomize people to the recommended therapy or to the regular therapy and show that the recommended therapy is better. And there are no trials with that yet. So we have all these prediction models, et cetera, et cetera. But unfortunately, there are no randomized trials yet showing that are better. Then we have this whole field of new and improved therapies, like cognitive bias modification, cognitive remediation. You have the whole field of psychedelic-assisted psychotherapy, transdiagnostic therapy. You have all kinds of new designs, the factorial trials and the fractional factorial trials. You have, yeah, I can go on. But there's a lot going on in terms of these new therapies. There's not yet one innovation that has been shown to really improve outcomes in routine care. So we really hope that this will happen and that some of these innovations will actually improve treatments. But you can imagine that, considering what I have seen over time with these effect sizes, I first have to see it before I believe it. And there's I should say that all these innovations are aimed at improving treatment outcomes, but also at improving uptake, because the uptake is a very serious problem. I mean, there are 1 billion people in the world with a mental health problem, and 80% live in low and middle income countries. So, and they hardly have access to a mental health treatment, an evidence-based mental health treatment at all. And in the high income countries, psychotherapies and treatments in general, the uptake of these treatments is low in general. Less than 50% of people with a major depression gets treatment. But it's even lower in adolescents, in older adults, in people from low socioeconomic classes, people from minority groups. When I worked in mental health care, we had a big problem with farmers who had high suicide rates and a lot of mental health problems, but who didn't seek help at all. So if you look at it from that perspective, psychological treatment and treatment in general is a very wide, elite, rich thing. And more than 90% of the people who need it don't have access to it, or don't use it, or don't want it. So the uptake is really a very important problem. How do we get these interventions and these principles of interventions to the people who need it? And there's also a lot of research on that. So you can work with single session interventions with much lower thresholds. You can work with lay health counselors which are nurses or students who are trained to deliver simple therapies. And so there's a lot going on in that field also, which does not have better outcomes as a goal, but to get it more to the people who need it. Yeah, and one thing, so when we look at these innovations, I'm not sure if I can explain this simply, but we wrote, if you want to know more about that, we just wrote a paper about this. So, no, I don't have that. So the idea is, so we have 42% of people responding to treatment. Of the remaining 58%, they will respond to 42% of those will respond to a second treatment. And then, so if you continue to treat people, then you can calculate how many treatments you need in order to get everybody better. And so probably it is true that if you don't respond to a first treatment, the chance that you will respond to the next treatment is a little lower. And so, and if people don't respond to 2 treatments, then we call them treatment resistant. But I think that's an artifact. It's just the logical consequence of the limited effects of treatments. And it's bad luck. 42% have luck because they get better with first treatment, but then you have 42% of the next, of the 58% remaining, they are still lucky. And then you have bad luck if you don't are not among the 70% or 75% who has responded to the first treatments. But to call that a different category, I think it's an artifact. And I think it's a matter of explaining that treatments to patients and also for clinicians to realize that treatments are just not so good. And you have to be clear to patients about that if you treat them, that you can be lucky and get better after first or the second treatment, or you have bad luck. That has nothing to do with your condition. It's just a logical consequence of the limited effects of treatments. But suppose you have the third treatment, and then you give people you give people that third treatment. Let's say the treatments remain effective on every step. That means that in the third step, you have also 42% of getting better. And it's probably a little lower because the chance of getting better is lower with an increasing number of treatments you have had. But if you have an innovation aimed at treatment-resistant depression, what is exactly your goal? Do you want that intervention to be as effective as these 42%? Or do you want it to be more effective than these 42%? But however you look at it, the impact on the total number of people you need, or the total number of treatments you need to make 100% of people better, that's probably only a tiny thing that you're capable of doing with getting a better treatment aimed at treatment-resistant depression. That's what we try to explain in this paper. So it's a very rational and but I think that's what we need. If we want to improve treatments, we need to, it's not going to be a silver bullet. It's not going to be like, okay, we have this innovation, which is double as effective as the treatments we have. No, we can, with a new innovation, we can go from 42% to 49%. And that will be a major effort to get that knowledge from 42 to 49. And maybe with another innovation, we're going to get from 49 to 53. And then, so all these innovations will be very costly, enormous research efforts. And then we will slowly get these percentages up. It's not going to be a silver bullet. It's a long-term incremental process if we really want to make a difference. Okay. I think that's I've talked enough. No, I want to show you, because we do have time. Yeah, this is the website from meta-analyses. And so it's a bit different when you look at your own computer. It's at www.meta-analyses.org. That's because this computer is, I think it's not the most recent computer, but it still works. So if you go to databases, you can go to overview, and you see here all the databases we have for psychological treatment for psychosis, for panic disorder, social anxiety, GAD, problem gambling, suicide. So these are all the databases you can go to on the website. They're open databases. And I will take the first one. This is the largest one, which compares psychotherapy to control groups. I hope it works. Yes. So you can go to start analyzing. And here it's indeed a bit of a strange, here you see all the studies which are included. You can download the whole data set, but you can also select a group here with data selection. So let's see, we're gonna focus on older adults. And we're gonna look at CBT. So does CBT work in older adults? I hope it works. It's a bit of a clunky interface like this. And then you click on Update Table. Yes, so here you see all these studies in older adults on CBT. And then when you click on Run Meta-analysis, you get the effects between study heterogeneity. How do I move to the other tabs? Oh yeah, here you have the plots here. So you have a forest plot. This is the forest plot. You can see what happens when you exclude outliers. Here you see the outliers. You can see you have all these publication bias analysis with p-hacking and funnel plot asymmetry. We have risk of bias, and you can even do moderator analysis. So it looks like this, a bit complicated, but that's, if you do it on your own computer, it's much simpler. And you can just run your own meta-analysis and group therapy for people with comorbid general medical disorders, digital therapy for students, whatever you want to examine. You can just run your own meta-analysis online. We use these shiny apps here. And you can do that, as I said, for psychological treatments for all these mental disorders we have here. We have many more data sets, also more updated data sets, but we cannot put them all on here. But and it's not something that my group is only doing. We coordinate the whole thing, but there are groups all over the world. I don't think there's a group in Canada, but there are groups in the US and many in Europe and Australia who are working on, who are the coordinator of one specific data set. And they have promised to do at least an update every year. And yeah, so we hope to harmonize all that meta-analytic research like this. Yeah. So thank you for your attention. Questions? No, the regression to the means happens in one group, but we only look at effect sizes, which compare the treatment to the control group. So it's not regression to the mean. That's not what happens. Yeah. We are diving into this now in more depth because it's weird to find this. What we do find is that there are some differences. We haven't published it yet, but I'm looking into this. We do find that in brief therapies, so up to 5 sessions, that people participating in that are a little less severely depressed as the people in the more extensive therapies. So that could be an explanatory function. We're also looking at the long term. So how does that do they still have comparable effects after 1 year, for example? But we haven't looked into that yet. But it's strange. It's really, you wouldn't expect it, but it's really what we find. Yeah. So it's not regression to the mean. Well, what could happen is that this phenomenon of sudden gains is very important, so that a lot of people get better within a few sessions. And then they stay in therapy because they want to finish it, so to say. But actually, if you look at symptom reduction, that has been realized in the first sessions. And if you then give a very brief therapy, then you have that same benefit. Whether that's a good thing to do, I mean, that's not what the research says, but that could be an explanation. Yeah, if you look at large populations, you have to think differently because you want to have a large impact and not an optimized effect size. Because even if the effects are very small, but you reach a large population, the overall impact is still very large. So if you go to India and you can reach 0.1% of the population there, you have I cannot count so quickly, but it's a huge population. And if you have a small effect then your impact is still enormous, which is much larger than you have when you take 1.1% of the Canadian population, you need interventions which are scalable, which can be applied in large population, and it's not so relevant if the effects are smaller, as long as it's highly scalable. So it's a bit of a different reasoning you need. And what we do, so I'm also director of a WHO collaborating center. So we do a lot of work with the WHO. And what we think are the best options for low and middle income countries, or here, if you work with large populations, is work with lay health counselors, single session interventions, and digital interventions. And we did a separate meta-analysis of digital interventions. And we, again, looked at guided self-help and unguided self-help. And usually we find that these two are very different. So guided self-help is as effective as face-to-face. And unguided is effective, but with much smaller effect sizes. We do not find that in low and middle income countries. In low and middle income countries, guided and unguided interventions have comparable effects. And that's still, I mean, that these are digital interventions, which means that a lot of people still don't have access to them, especially the poorer group. But the number of people with mobile phones is increasing rapidly, even in poor countries. I think it's now at 85%, something like that, of the world population. Don't pinpoint me on the exact number, but it's increasing fast. So digital intervention.